Top Med Talk.
Well, good evening. Thank you for that warm, wonderful welcome. I'm Desiree Chappell, host and managing editor of Top Med Talk, and we are here tonight at the Montague in beautiful London, England, for the Edwards Life Sciences Dinner Symposium, The AI Doctor Will See You Now. Now, tonight we're going to be having a great evening of wonderful, in-depth conversation. We're first going to be hearing from Monty Milan, who is professor at the University College London of Anesthesia and Critical Care, and also editor-in-chief of Top Med Talk. But before that, I do want to let you know we are live streaming this event, so this is going out to the world. And for everyone that's in the room and listening abroad, you can join us for conversation via Slido.com. That's an interactive Q&A platform that you can ask questions. So if you want to pull your phones out here, or if you're at home, wherever you are listening, Slido.com. The event code is HPI. So that's going to allow you to ask questions throughout the evening. And we really encourage that. Please ask those questions. Let us know where you're from, who you are. If you're in the room, please don't hesitate to ask questions as well. Just make sure you grab a mic. So without further ado, I'm going to introduce Monty Milan and invite him up to the stage to give us a short didactic presentation on artificial intelligence.
Oh, thank you. Not all intelligence is artificial, I'm told. So thank you very much indeed for joining in, everyone. Hi, everyone around the world, a loyal audience. I'm going to start by just commenting on some guidelines that were published very recently. Published in JAMA Surgery. They're a new set of guidelines for perioperative care in cardiac surgery from the Enhanced Recovery After Surgery Society. And this is actually a new society specifically about cardiothoracic surgery. So any of you in the room who do, or listening elsewhere, who do cardiothoracic surgery might think, hang on a second, that's sort of ERAS stuff, isn't that all colorectal, isn't that all urology, maybe a few joints, etc., etc. It now seems as though enhanced recovery after surgery is suitable for all patients having all forms of surgery, both elective and emergent. Now, it varies with regards to the type of surgery. There are some subtle variations in the cardiac ones. If you look the paper up, published in JAMA Surgery, May the 4th of 2019, you can find it online. Apparently, the most downloaded paper ever in JAMA Surgery, we're told. So it's been extremely popular. You'll find within it a chart of recommendations that are graded from 1, 2A and lower. And there are about 20 that are in the sort of high-ranking recommendations. And a few of them are cardiac specific. But most of them, when you look closely at them, are the same principles as you see in all enhanced recovery programs. So that is patient preparation. Great emphasis now on prehabilitation, which is what we've been doing today. We've been attending a conference, the Third World Congress of Prehabilitation, sold out here in central London, held at the British Museum, in partnership with evidence-based perioperative medicine and so-called POETS, which is the Perioperative Exercise Training and Testing Society, POETTS. Now, when you look down the list in the paper, you'll see a couple of things that are cardio-specific. You'll also see emphasized goal-directed therapy. You'll see emphasized smoking cessation and avoiding hazardous alcohol consumption. And further down the list, you'll see prehabilitation. So the idea if we're really going to make a difference to these patients, we have to get them very well prepared for surgery. Hemodynamic management's always been at the heart, excuse the pun, of cardiothoracic surgery. But more recently, we've become very focused on the idea that there's a mean arterial pressure below which we shouldn't allow our patients to go. Now, when I was a youngster brought up doing on-pump bypass, one of the things that shocked me the first time I went into the heart room to see patients on bypass is we would let the mean arterial pressure go down to 40, 35, 30, and you think, whoa, I feel very uncomfortable here. And not all our patients did great. Now we're accepting the fact that in almost all forms of surgery, a mean arterial pressure of about 65 is the lower limit that we should tolerate. Now, very recently, published in the May edition of the British Journal of Anaesthesia, there was an editorial and 4 papers about perioperative blood pressure measurement from the group called POQI, P-O-Q-I, which is the Perioperative Quality Initiative. Now, we're sitting downstairs in the great Russell Room at the Montague on the Gardens Hotel, just across from the British Museum, having this sponsored dinner symposium. In this room, 2 EBPOMs ago, a group of alleged international experts gathered for 2 days to pore over the issue of perioperative blood pressure. They considered the physiology of blood pressure, they considered preoperative blood pressure, intraoperative blood pressure, and postoperative blood pressure. And their findings are published in 4 papers, consensus guidelines, in this edition of the British Journal of Anaesthesia. Now, the physiology paper is, I think, a great read. The first author is Gareth Ackland. You'll recognise some of the other authors on the physiology paper. One of the things it reminded me of is about autoregulation. Now, we all think we know about autoregulation. We know that there's a threshold of blood pressure, a high and a low, that maintains flow constantly in the organs of our body. And normally we think about that with regards to the brain. What I'd sort of forgotten about is the autoregulation point is different for different parts of your body. It varies with age and it varies with your pathophysiology. So the fact that your cerebral autoregulation points might be being maintained doesn't necessarily mean you've maintained your gut and your kidneys. So if you've forgotten about that, as I had, I encourage you to have a look at that physiology paper. It's also made it onto the front cover of the British Journal of Anaesthesia. With regards to the intraoperative paper, I'll come back to the preoperative and postoperative in a second. The intraoperative paper, the key thing that came out of it was that based predominantly on observational data, a mean arterial pressure of less than 65 millimeters of mercury during surgery for as little as 1 minute is associated, and I'll come back to associated in a second, with adverse outcomes. And those adverse outcomes include death, stroke, myocardial infarction, and acute kidney injury. Now, 1 minute below 65 is pretty low risk, but it is an increased risk. Do you ever let a patient get a MAP below 65 for a minute or longer? Possibly. Yeah. Yeah. Obviously, the more profound the hypotension and the longer it goes on for, the greater the risk. So if you happen to have a period of, say, I don't know, let's imagine you've induced anaesthesia, you've gone into the operating room, you're waiting for the surgeon to arrive, the patient's draped, and it's below 65 for 10 minutes, the risk is much, much greater. Now, the other bit of news from our perspective, if most of us in the room are anaesthesia providers or critical care or nurses in this space, I don't know if there's any surgeons in the room, is that a lot of the harm, the signal of harm, is between induction of anaesthesia and so-called knife to skin. And there's only 2 people to point the finger at for that. There's the patient, and that seems a bit harsh, okay? And there's the anaesthesia provider who pushed the drugs and waited for the person to arrive. Now, there's only really one interventional study so far that suggests the fact that keeping the blood pressure up is associated with a better outcome. It's not really big enough to definitively say keep the blood pressure up, but the association with the blood pressure being low and harmful is very strong. So the consensus statement here said, pending availability of new evidence, keep the MAP above 65. Now, I can hear you saying all those other things that are discussed in the paper. What about the baseline blood pressure? How should you keep it up? And how should you keep it up is probably informed by the so-called goal-directed literature. In other words, stick to basic principles, go volume, then flow, then pressure. So still go to the idea of give a few boluses of fluid. If it's not working, give a little bit of squeeze, get the MAP above 65. And use your advanced hemodynamic monitoring to inform that decision-making. Now, preoperatively, there's not a lot of new news. It still seems that there's no absolute level of blood pressure, be it high or low, in a patient who presents electively that should result in delay in surgery. We still kind of go for a systolic of 200 out of the blue to suggest the fact that you're probably not going to get through the system without somebody stopping you getting to elective surgery. But there is no evidence there to suggest that that's actually a harmful decision. It's just kind of pragmatic to say at some stage someone's going to measure your blood pressure and cancel you. So you should probably go and get it sorted out before you get cancelled. Okay. For the post-operative bit, there's a really disturbing paper, because one is we had very little evidence to discuss. The evidence we could find was again based on observational data, and when blood pressure has been measured more continuously post-operatively, it seems that hypotension is common and often missed. And the harm signal associated with hypotension the first 1 to 3 days post-operatively is multiple times higher, 3+ times higher, the risk signal, than during the case. So we've really got to do something about that as well. But at the moment, we're really focused on the intraoperative bit and the immediate post-operative bit. Now, in the post-operative paper, there is a cartoon in there, a diagram that was drawn, that shows the challenge we have with our current monitoring cycles. So you'll see in there a graph, if you pull out the paper, that has the period of time, immediate post-operative period, day 1, day 2 and beyond. Then it has 3 lines on it. It has a green line, which is the line of hope. It has the blue line, which is the line of something that might happen soon. And it has the yellow line, which is the line of today. And the yellow line represents the fact that unless you're going back to a high dependency unit or an intensive care unit, it's not going to be long until your blood pressure is not being measured very often at all. Whereas when now, in some papers published recently, they've used more modern technology, devices that allow more continuous blood pressure measurement, that you can get to having continuous blood pressure measurement out to about day 1 and multiple episodes of serious hypotension are being detected. We hope it won't be that long until there are sensors available, microsensors, transmitting sensors. They're already being tested at the moment that will allow continuous blood pressure measurement. My final point I want to make is the point about this evening's discussion. So we kind of all would probably accept the fact that hypotension is bad for our patients. We'd kind of like the idea that we could have continuous non-invasive blood pressure measurement more easily, more readily available, and more affordable. But what about going one stage further? What if we could predict hypotension? If 1 minute of a mean arterial pressure below 65 is bad for you, you're going to have to be pretty focused on what's going on around you to get in there at a point whereby you can stop that little bit of transient hypotension going on for a minute. So what if there was a technology available that told you, based on analysing all the characteristics of the arterial waveform and more, that it's highly likely that your patient that you're looking after will have a hypotensive episode in the next 2, 5, 10, 15 minutes. Well, now there's a new technology which is being developed by Edwards Life Sciences, and one of the, let's call him inventors, is in the room tonight. We'll come to him for a conversation in the break. And it's called HPI. We'll tell you what HPI is later. But I've got up for those in the room, I've shown up an article from the Wall Street Journal, published relatively recently, called "The AI Doctor Will See You Now." So it's in the Wall Street Journal, so it must be true. It's talking about the very few artificial intelligence technologies, machine learning, that have been approved to date. And the particular one it's talking about is the Acumen technology, the Hypotension Prediction Index from Edwards Life Sciences. It has on the new screen, this is approved now. It's been approved in Europe for coming on for 2 years now. It was approved by the FDA in the USA in October last year. The monitoring device now has a number on it, which goes from 0 to 100. The higher the number, this HPI number, that we'll come back to in detail after the break, the greater the likelihood that your patient is going to have a hypotensive episode. And the predictive characteristics seem quite extraordinary. As it starts to rise, let's imagine it's going on at about 10 or so, the number increases, and as it increases, it's saying the likelihood of hypotension is growing. It's a bit like a weather predictor. It gets up to 50%. It says, it might rain, it might not rain. But if I was you, I'd think hard about whether you think it's not going to rain, because there's a 50% chance it is going to rain. When it goes up to 70, it says, it's probably going to rain. Yeah. By the time you get to 85, it's saying, it's going to rain! So we'll come back to that after the break. So that's HPI. So that's the tee up. I want you to take a break now. Those of you at home, go and put the kettle on, whatever you do. Those in the room, take a quick bio break and then top your glasses up, whatever you want to do. And in 5 minutes' time, we'll come back and have a good chat with our special guest, one of the developers of HPI. Thank you.
Top Med Talk. Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.